All right, this is our last section. Everyone excited? Don't look sad. You get a whole another 2 semesters with me. So, and this is the end of the easy stuff, like the actual Farm 1 and Farm 2. That's where the real fun begins. So, that's where you have to actually know drugs and things like that. Again, some people like they don't do well with this class because they have a harder time with it because like they're not like a really conceptual kind of person, right? And so it's hard to like, okay, how can I apply this to a real situation? Sometimes that's hard when you're just talking about the concepts. Some people really flock to Farm 1 and Farm 2 because that's when we get into actual like treatment of disease and things like that. So say you have a hypertensive patient, here's their history, here's their labs. What drug do you want to use for that patient? Some people do a lot better with that when they can say, okay, well, I know this about this drug, so this is no good. I know this about this drug, this is no good. This is the perfect one for them, right? So some people like that a little bit more kind of clinically relevant, practical sort of application. And so it just depends on the type of person. But we'll talk about it. We'll get to it. But again, don't freak out too much about Farm 1. It is not that bad. There's a lot of memorization. It's a lot of information, but and sometimes it's almost like learning a second language, you know, like being able to say things like hydrochlorothiazide or some of like the new biologic products like adalimumab and things like that are kind of a mouthful, but we'll get some practice and you'll get kind of comfortable saying those drug names. Anywho, so today I just want to talk about dosage regimen. So kind of pulling in all that information we've learned throughout the semester into how do I actually apply it to a patient here, right? So there's this concept of rational prescribing. Now, does irrational prescribing ever take place? Absolutely, all the time, right? So imagine your patient shows up and they complain of a cold. You know it's a viral illness, and then what do they get anyway? They get antibiotics. That's irrational prescribing, right? We want to make sure that you guys are not going to do that. That's why I teach PAs. I want to teach every single PA in Florida by the end of my career if I can, so I can try to make sure you guys know what you're doing when it comes to drugs, right? Because it is such a big thing, because so many patients are going to need drugs, right? Now, of course, you guys are going to be the experts on making the diagnosis, right? So you're going to figure out what the heck's wrong with your patient and then deciding what are we going to do about it, right? So do they need surgery? Do they need health education? No therapy at all? That's always great if you don't have to do anything with the patient, so it's a benefit. However, medication is the most commonly used, right? Because again, it's very oftentimes easy for the patient to take. They can just take a pill and it fixes their problem. Great. But it also requires a prescription, right? So we're going to talk about prescription writing a little bit here, and that is going to inform what you do for your actual assignment you're going to turn in next week. But when a patient comes in for the visit, you know, they want you to do something. They don't want to just walk in, they feel really crummy, they got a low-grade fever, they just feel bad, and then you say, well, it's a virus. And they say, okay, well, give me something for it. And they're like, there's nothing to give for it. And they walk out and they're going to be mad, right? Because they're like, well, you didn't do anything for me. You just told me what I already knew. I feel bad. Great. So because of that, there's a lot of prescribing that occurs because, again, that does help patients to feel like you actually did something right. Not always rational, but that is something that occurs from time to time. You know, 2/3 office visits usually end up with some sort of prescription being written there. And patients usually get about an average of 1 prescription per visit, depending on kind of what their ails are at the time when they come in, depending on how their diseases are progressing, et cetera. So when you're deciding what drug to give for these patients and you write that script, what's the stepwise approach you're going to take in order to come to the right decision on what you're going to give to them? So step 1, obviously you want to make the accurate and specific diagnosis, right? So because patients want you to do something, even if you have not sure about what it is that you're dealing with, you know, they might write your prescription anyway. I'm not really sure if it's viral or if it's fungal or bacterial. I'm just going to write you a prescription for an antibiotic anyway. Not great because, one, that's unnecessary cost for the patient, right? So again, they're buying something that's not actually going to treat their disease, not actually going to make them feel any better. Using antibiotics unnecessarily is going to do things like resistance. So things like Z-Packs. I'm sure everyone's probably heard of someone just getting a Z-Pack when they have a you know, upper respiratory illness or something like that. That leads to resistance. Z-Packs become less effective the more and more you use them because of the bugs getting smarter and they're getting more likely to be able to fight off those antibiotics. More adverse drug reactions, right? So sometimes the adverse reactions they're going to get from the medications they take are worse than the actual disease they're trying to treat in the first place, right? So again, no good. But you at least need to start with some sort of tentative diagnosis, right? So some idea of what actually is going on with the patient if you don't have, you know, the definitive one. So let's say, for instance, we're going to start off with a patient with probable rheumatoid arthritis, okay? And you guys don't know everything about the disease state, but we'll kind of walk through the steps. So let's say we've done the labs, we've done the exam, we think, okay, this patient probably has RA, okay? And again, you want to share that with the patient, say, hey, this is what I think it is. I don't think it's osteoarthritis because X, Y, and Z. I think this. Walk through your differential a little bit. So you want to make sure you kind of think about what the actual pathophysiology is, right? So much of what I'll do in pharm, say we talk about hypertension. Well, you can't know what drugs to use for hypertension until you know how hypertension occurs, right? So what are the different systems that get involved here? With RA, you're going to see a lot of it is due to the autoimmune reactions that the body's developing against itself. It's inappropriate, but it's very inflammatory based. You're going to find that in order to deal with that, to treat RA, you got to deal with the inflammation, right? So you're going to find that you're going to use drugs a certain way, or certain drugs based on their mechanism, based on the pathophys. Okay, so that's why it's so integral that you know that, so very important. And again, when you're communicating with your patients and trying to describe the disease state to them, you always have to talk to their level, right? So for instance, if I'm back at home and I was working in Palaca, Florida, and I'm trying to describe, okay, these prostaglandins are being sensitized and you have all these neutrophils that are going to the joint, and they're not gonna have any idea what I'm talking about, right? And my dad, he is a CRNA for many years, and then he moved into risk management, did a lot of talks about medication safety and things like that. But like some of the things that patients will come up with to describe their disease states is kind of interesting. Because they just don't have that medical knowledge. So for instance, if they say, I got the high blood, that means hypertension, right? Their blood pressure is high, right? Or I got the bad sugars. Their sugars are too high, right? So things like that, where you're going to find that like you need to talk to their level, make sure that they understand what you're actually trying to communicate to them, because you can go way above their level very quickly, and they're just going to sit there going, and have no idea. I see that all the time with you guys, in every class I teach. I see that, and that's why I'm like, okay, let me stop. Let me go back and re-explain this, right? See those blank stares. Anywho, but again, there's lots of good resources online. Places like the CDC, places, a lot of different like governmental websites will have good information on trying to explain things, to your patients. Another big thing we run into is a lot of language barriers as well. We have a very high Hispanic population here, so you need to make sure that you have resources that can either translate for you. So we have like this little iPad that we can roll around the ER that has translator services on it. If you have specific like Spanish printouts and things like that, that's going to be very helpful, because that way the patient gets all the information they need, right? Or if you speak Spanish, even better, right? Mi español es no good. I'm still learning. I'm doing Duolingo right now, so I'm working on it. But I'm still like on level 1. I'm like la manzana es rojo. Like that's the level I'm at, like kindergarten stuff. So anyway, so now you have an idea, okay, how do I describe what's the pathophys behind RA, right? So against this autoimmune condition, the body is inappropriately fighting itself, essentially. Now you have to figure out what the therapeutic objectives are going to be. So what are you going to do for your patient in order to what do they come in for in the first place? They probably came in for pain issues, or maybe their joints aren't really working like they're supposed to. So you have to just define kind of what your problems you want to treat are. So in this case, you may have, say, 2 different goals. One, you may want to relieve the pain associated with that inflammatory process, right? It's going to be good for patient quality of life. And a secondary goal you're going to know, based when we talk about RA, is going to be arresting the course of the disease process, right? So basically preventing it from getting any worse. Now with things like RA, things like CHF, things like that, can you reverse the process and get the body back to where it was to begin with? No. We're all steadily breaking down, getting closer and closer to being shuffled loose, the mortal coil. So we can't fix a lot of things, but we can hopefully make it slow it down from getting worse over time, right? So that's one of the other big things we'll focus on, is try to see if we can maybe slow down that progression, right? And again, depending on what the case may be, you may find that your goals can change drastically, right? So if you have a patient who's only got 6 months to live, they're in that kind of hospice care sort of state, that palliative care sort of state, you may find that, well, I don't actually care about slowing down this disease progress, because I know this is not going to do anything for the patient. Let's at least make them comfortable till the end of life, right? So again, quantity versus quality of life, these are the things you'll consider here when you're just, selecting your therapeutic objectives. And again, based on the different goals, you're going to find you may have totally different classes of meds you're going to use in order to treat that, right? So again, I may have one thing that's going to be good for pain, and then another thing that's going to be good for actually helping with the disease progression itself. Okay, so then you're going to find, okay, what's my drug of choice, right? So again, based on each of the goals, you're going to see, okay, is there any way I can combine drugs together to get maybe kind of dual benefit out of it? Do I need, how many different medications am I looking for? And then look at the patient themselves, right? What's their age? What's their other disease states? What other medications are they already on that may be interacting with things I want to add on to this patient, right? So for instance, with RA, because we know that inflammation is a big deal, we're going to give them a lot of anti-inflammatories. We know once we go to the GI section, we'll talk about this, that you need things like prostaglandins, you need things like that in order to help make sure you keep the mucosal barrier up on the stomach. Otherwise, all the stomach acid is going to eat right through. So do they have a history of GI ulcers, right? Do they have a history of things like aspirin intolerance that may preclude them from a certain class of medications, right? Is cost a big issue? Do they have any insurance? Who can say, right? So it depends on the patient you're dealing with, what are their access to resources, et cetera. Maybe nice to say, hey, this new NSAID is like the best drug out there, but it costs $1,000 a pill. May not be great for your patient if they can't afford it, right? They're not going to take anything. And then, think about things like compliance. Is once daily dosing important? Is trying to combine these into combination meds, so that way they're taking fewer pills. That's always going to be a good thing from a compliance sort of standpoint. But, what can they actually take? So, for instance, some of these drugs you're going to find for RA come as an injectable product, right? Because they're proteins you can't take orally. So they'll have to use a pen, basically, to inject themselves into, say, the abdomen. Well, with RA, what's one of the big problems with their joints? They degenerate over time, right? So they may not even have the dexterity or the ability to actually give themselves that injection. That's a big consideration there. Do they have something that can help them? Things that you're going to be thinking about. So then you're going to determine the appropriate regimen. So you're going to think about things like the kinetics of the drugs. You're going to be thinking about things like organ impairment. Do I need to change how often I'm giving the drug? Do I need to change the dose? All that goes back to things like what's their liver function doing? What's their renal function doing? And then is the patient actually going to be able to tolerate it, right? So I may have a great drug that I need to give 6 times a day, but the patient's like, I can't even remember to take anything 1 time a day, right? I can barely remember to put on my pants before I leave the house. May not be best for them, right? So again, think about these sort of considerations. Maybe using a long-acting medication, maybe using a transdermal drug that you only have to give maybe once every 7 days or something. These are things to think about. Then you're going to think of a plan once you got your drugs down, what dose you're going to administer. You have to think about the monitoring, right? And then be able to describe to the patient what are you actually looking for, not in so much as just adverse effects, but also with efficacy. Like when should you expect to see differences? What should you expect to see? What is a side effect versus just say progression of the disease, right? A lot of times patients may not even know what they're experiencing as a side effect until someone actually educates them on it and lets them know. Other things include like, laboratory testing, what do they need to do? So for instance, with RA, those injectable products I talked about are very potent immunosuppressive agents, but whenever you suppress the immune system, what is another possible side effect of that from the patient side? Infection, right? So things like, why do we need to test this patient for TB? I came in for RA, now you're testing me for tuberculosis. Well, that doesn't make any sense. Well, we need to test you because this may activate a latent infection, right? These are things you need to educate the patients on. And then describe like what's the rationale? Why are we using this type of drug versus this type of drug? Because oftentimes patients will come in like, hey, I saw a commercial for this drug. Why aren't you giving me that one? Well, there's a whole host of reasons, and let me go into why I think this is a better drug for you based on X, Y, and Z, right? But for instance, a patient comes in and they say, hey, I have an infection. You say, I'm going to give you a Z-Pack. They go home and they feel better after day 3, but it's a 5-day course. They say, well, I don't need to take this anymore. I can save it for later. You need to explain the rationale. Yes, you need to eradicate that infection completely, even though you may feel better. You just still need to take the whole thing, right? And then other things like, things that would constitute a change, either coming in to see you to get, further care, maybe switching out a drug, maybe warning signs, you need to go to the ER, things like that. For instance, if you're giving your patient an NSAID, what are some signs of a GI bleed, right? So again, they're having antihemetemesis or they're having dark tarry stool, things like that could show the patient's GI tract is having a bleed. Not great, right? Those are things that would be warning signs. We want to get the patient off that drug immediately, right? And then get a plan for patient education, right? So you want to be specific with like age barriers. So if you're dealing with the kids, you have to explain things different than a 2-year-old versus a 16-year-old. 2-year-old's not going to be able to get any of that information. That's why you need to educate the parents, who oftentimes may not have greater than a high school education, as the case may be. So you need to think about talking to their level. Language barriers, educational barriers, etc. Utilize educational materials whenever you can. So for instance, here's a drug called Diastat. This is actually a rectally administered medication. Anyone know what you use this for? Ever heard of it? It's used for seizures. So if you have a patient who had a seizure, you need to administer them medication very quickly. Oftentimes, if they're having a tonic-clonic seizure, you can't give anything orally. So what we'll do is we'll use rectal medication occasionally. So basically, and imagine being a parent, and all of a sudden your kid starts seizing, and now I got to figure out how to give this medication rectally. So it's going to be a pretty harrowing sort of experience. But if you educate them beforehand, you at least try to get them prepared. So okay, make sure you take their pants down here. Make sure you open this up. The dose is already pre-programmed in. You don't have to think about the dose. Make sure you apply the lubricant, because otherwise that can cause trauma to the rectum. Things like that, so that way they're at least prepared when they actually need to administer it. And again, lots of printouts and things like that are available that can help you out with that as well. And again, pharmacies do provide drug information, but don't always assume they're going to give them all the information that you might have. Don't think ill of your other counterparts in the medical field, but just assume that you're the last line of defense, right? So because again, if you talk to the pharmacist who's working at Walgreens and are filling 300-400 scripts a day, they're very busy. They have a hard time stopping to take time to talk to patients. They should. They absolutely should. However, they may not be able to, right? That's why I like so much work on the hospital side, because I can go in the ER, I can go and talk to the patients, I got time, I can do that sort of thing. But when you're actually out there in the real world, that may not always be feasible. So that's why, again, that's why I love like mid-level practitioners, because you guys do have the time. You can sit there and talk to your patients, and oftentimes the most education they get is from their PA or their nurse practitioner, right? So again, that's why your field is so valuable, right? Well, no fist pump. Anyway. Right. So let's look at an example. Let's look at a patient. Let's say we have a 3-year-old patient who's presenting with left ear pain. You go ahead and get your otoscope out. You take a look at that and you say, that probably looks infected, right? Come in, they got a fever, cough, and runny nose. So what are you thinking? Probably thinking otitis media, right? So again, if you don't know that, it's okay. That next semester. But so again, we want to make a specific diagnosis. We're saying, okay, well, I think this is going to be acute otitis media. You got to explain the etiology to your patients, right? I think this is actually going to be more likely to be bacterial. Could be some virus in there, but I think most likely based on your presentation and whatnot, I think this is bacterial, right? Next, consider the pathophys, right? So with antibiotics, we're going to find that you need to know what kind of bugs you're treating. We talk about bugs and drugs. If you don't know the bug, you have no idea what drug to actually use. And so you're going to find that when you get into specific disease states, you're going to see that skin is going to have specific types of bugs associated with infections versus the GI tract versus the CNS versus the urinary tract. And so you're going to get a feel for that over time, especially when you kind of work with these patients. And you're going to know that when you look at some of the acute otitis media, you're thinking of things like strep pneumo. I'm thinking of things like H. influenza. It's not important you know that right now, but just for our examples here, I'm telling you what the most common bacterial etiologies are, right? And so that's good because it helps us to tailor down what sort of antibiotics I want to use, okay? We'll talk about spectrum of antibiotics next semester, and again, it's the first thing we're going to cover, so this is pertinent. We kind of talk about it here. We'll talk about things that have a very wide spectrum that treats every bacteria under the sun practically, and things that have a very narrow spectrum. And again, in this case, if I know it's probably 2 of the different bugs, I want something very narrow, because again, by having much more laser-focused sort of approach, you run less of a risk of having things like resistance develop and things like that, right? We like to reserve our antibiotics as best we can, so that way, if it's not the zombies that take over humanity and kill us all out, it'll probably be the bacteria, right? The super bugs we're trying to garner here in the hospitals. Anywho, but again, looking at this, using an antibiotic that's not going to cover the bugs that they're infected with, it's not going to do anything for the patient. You're going to see resistance. You're going to see they actually don't clear their infection. It's going to be no good, right? So you want to make sure you have a good idea of what bugs you're dealing with in the first place. And again, provide that information. Hey, I think it's this likely to be these type of bacteria. You don't have to go into specifics. I think it's strep pneumo. Blah, blah, blah. Just say, hey, I think it's a bacteria. I think this is why we're going to go with antibiotics versus anything else, right? So, places like the CDC has really good information out there, right? And so they can tailor it to different education levels, whatnot. So again, you can reference patients back to these sort of references. Most of the time, by the time they come in, they're going to be Googling everything anyway. So they come in and say, hey, this site says, kiddoc.ru.biz says that, it's probably cancer. Oh my gosh, my kid's going to die. And he's like, no, let's actually go to some reputable sources, right? Let's look at the CDC. Let's look at, I guess it depends on how much you trust the government. But places like the CDC usually pretty reputable for the most part, right? So things like that can be very useful to give them baseline information on what the disease is, how they expect to treat it, what to look for, etc. So next we want to look at our therapeutic objectives. So one goal would be to eradicate the bacterial infection. That makes good sense. So we need to make sure we have appropriate antimicrobial coverage. And then the next one would be to treat the sequelae of disease. So the kid came in with runny nose, fever, they feel pretty crummy. What can we do about that, right? So for instance, what can we do as far as from the inflammatory response? How can we mitigate that to hopefully break the kid's fever, right? So we're going to select a drug of choice. Again, we're looking at the patient's age. We're looking at their organ function, previous allergies, right? Especially with antibiotics, you want to consider what allergies they have. It may preclude you from using certain antibiotics. And then look at previous versus current medications. This is important, especially in pediatrics with recurrent infections, because what they've been on previously may not work for this infection, right? So again, they may have been on amoxicillin before, but now the bugs that they have are resistant to that amoxicillin. Now you got to step up your game. Now you got to go to something bigger. So look at things like what previous antibiotics they're on. Like if it was 2 years ago, not a big deal, right? Versus if it was 6 weeks ago, that's going to be much more likely to see a resistant bug. These are considerations you're going to make when talking to your patient, getting the history, etc. Right? And again, use your resources to find what appropriate medications are going to be good for them. So some good drug references. Some of you already started using these, which is good. So things like LexiComp, which is built into UpToDate. You guys feel like you're getting some good use with that. Other ones out there, Micromedics, Clinical Pharmacology. These are all things you're going to, depending on where you work, you'll find that they have a drug reference of choice. They have a subscription to that. It just depends on where you work and what they use predominantly. Now, other things. You guys ever heard of the Sanford Guide? Sanford Guide is wonderful from an infectious disease sort of standpoint. Again, infectious disease is going to be the bread and butter of many different specialties you can go and work in. So it's good to have a good idea of what antibiotics are going to work for different types of infections. It's very good because it'll actually go through and show you, okay, I have this sort of disease state. What's going to be the first line drug? How do I dose it? Okay, to have an allergy, here's the second line drug. How do you dose that? How long am I going to give it for? Very quick references, but there's many of them that are out there. There's another one called the Red Book that's good for just pediatric infectious disease. So know your references, know your resources where you can go to get good, accurate information, right? And then also, clinical guidelines are very, very useful as well. That's where you're going to get the most up-to-date organization sort of recommended regimens for things, right? So if I go to the Infectious Disease Society of America, they're going to have very up-to-date most of the time up-to-date recommendation, but usually kind of the last word as far as what the standards of care are going to be handled through those kind of organizations, right? American Academy of Pediatrics is another big one, especially for a lot of kid-based illnesses and things like that, right? So use your resources. Okay, so then look at the drug selection considerations. How often is a drug given? Do I want to give something, 4, 5, 6 times a day? Probably not, right? Anyone try to give medication to a kid orally before? It's no fun, right? So if I can get someone 1 time a day, 0 times a day would be great if I could do that. But 1 time a day is going to be a lot better than, say, 4 times a day, especially with a 3-year-old. What are the dosage forms that are available? Are liquids available for little kids, right? Because they don't want to take a big tablet, right? They're not going to be able to swallow that. Sometimes drug shortages can influence what you actually have available to you, right? So again, if they're out of one particular version of a drug, that's just not going to be there. It doesn't matter how much you prescribe it. If they don't have it at the pharmacy, they're never going to fill it, right? Looking at cost, the insurances, maybe there's free antibiotic programs at certain, pharmacies. Those are big helps to a lot of patients. I'm sure it's a help to the store as well because they have people coming in and you're more likely to buy other stuff. So, go to Publix to get the free antibiotic. I better get some Pedialyte while I'm here and better get some X, Y, and so it works out for everyone in that case. And then also, how palatable is the medication? What's the texture like? What's the flavor like? There's some meds that I remember when we first started up Nemours, we buy a boatload of Tylenol because a lot of fever's coming in, right? And all the nurses were like, we got to get rid of this cherry Tylenol. This stuff is the worst. And we're like, who cares? It's Tylenol. They're like, no, these kids are spitting everything out back at us. It's no good. We need something different. Got to get the grape Tylenol. The grape Tylenol works great. Everyone loves that. And then there was a shortage. We couldn't get the grape Tylenol. We had to go at the cherry. It was almost a mutiny. It was bad. So again, think about things like palatability because if they don't want to take it, they're not going to take it, right? So here's an example of looking at, here's a guideline that gives you the information on how to treat acute otitis media. I believe it's from the AAP or American Academy of Pediatrics. So you'll see here what they recommend. So look, you can see here, okay, initial, immediate, or delayed antibiotic treatment. That sounds like our patient. They're presenting new onset of this acute otitis media. You can see here, okay, recommended first-line treatment, amoxicillin, 80 to 90 mg per kilo per day in 2 divided doses. Does it look pretty similar to what you might have on a prescription writing assignment, perhaps? I think that's what I gave you guys. But what's the alternative? What can you use if the patient's allergic? Okay, well now I can use ceftonir. It's going to be a backup drug I can use instead. Or what if the patient couldn't take anything orally at all? What if they're so having so much nausea, vomiting, they just couldn't take anything orally? Maybe there's going to be other alternatives. Maybe I can give them something like ceftriaxone. This is an IM or an IV sort of drug. So this gives you all your options, so that way you know whatever you pick is most likely going to treat that patient's infection, right? Versus say they come back and they're 48 to 72 hours and they've had failure of that initial antibiotic. Well, what do you go to as the next step? They come back, they're still sick. What do you go to next, right? So this is why guidelines are so important, why they're so handy, because they will give you all the information you need exactly what to treat, right? You still have to think about things, but these are very good starting points. Okay, so let's say we decide we're going to treat our patient. We're going to have amoxicillin suspension. We're going to dose them at 90 milligrams per kilogram per day divided twice a day. We know the suspension comes as a 400 per 5 ml solution. Okay, why is it per 5 mLs? It's the teaspoon, right? Good. Patient weighs 20 kilograms. So the question is, how many mLs do they need per dose? That's what you're going to write on your prescription itself. So, okay, so we're going to go through this. How many mLs do they need per dose? First thing we need to do, figure out what their daily dose is going to be, right? So we're going to take that 45 mg per kilo per dose. Actually, in this case, I'm going to just divide that by 2, right? Because I'm getting per administration. So I'm going to say, okay, well, I'm going to take that 45 mg per kilo per dose. I'm going to multiply by the patient's weight, so I know they need 900 milligrams per dose. Okay, makes sense. So again, how do I convert that over into the actual mLs they're going to need per dose? Well, basically, I know it's 400 per 5. If I divide that out, it comes out to be 80 milligrams per ml. Good. And again, I hate that nomenclature, but a lot of bottles still do that. So again, it's just something you have to work through. So 80 milligrams per ml. So I'm going to take 900 divided by 80, and I get 11.25. So you could write 11, you could write 11 and a half, whatever, 11.25 is fine. So basically 11.25 mLs twice a day, PO for, and then you look at back at the reference and say for 10 days, right? Again, duration is very important for antibiotic treatment as well. You don't want to go too long, you don't want to go too short, you want to get it just right. Okay, make sense? Straightforward. Next, we're going to look for a plan to see how we're going to determine what our endpoint of therapy is going to be. We're going to look at things of efficacy. Obviously, the patient, their ear pain is getting better. If their fever is breaking on its own, things like that are going to be signs that yes, the antibiotic is working. But what are some things that might lead them to come back to you, right? So again, it's been 2 or 3 days. It's still just as bad or worse, right? Those are things you want to educate them on and say, hey, this is when you want to come back and come see me because you might need something different, right? And again, explain the rationale why they need the full course to make sure that they take it all as they should. Just kidding. Okay. Right. So again, that rationale for taking the full dose is very, very important because otherwise people will only take half of it. They'll squirrel it away. They'll give it to their friend the next time. Hey, I had the same thing last year. Go ahead and take some of this. It'll fix you right up. No good. You know, and then other things like, you know, what would constitute a change in therapy? Say, again, they're not improving over a couple of days. Say, for instance, they have an allergy. What does an allergic reaction look like? What is something that is just a normal side effect? These are things you want to educate them on. And then, obviously, you get that, patient education. You are going to have things like language barriers to deal with, education barriers. Dealing with a 16-year-old is different from dealing with a 2-year-old versus dealing with a 40-year-old. So, again, you want to make sure you're explaining to the right levels there. Yeah. Okay, so any question on that idea of rational prescribing? That's what you should do with every single prescription you ever write. Probably applies to a lot of other things in medicine as well, but that's kind of the general approach to things you should. And again, you may not think about that and so far as every single step along the way, but again, that's what the general approach you should take when making that final decision. Okay, what am I actually going to put pen to paper? What am I actually going to write down for that patient to fill? Okay. So anyway, so getting into the prescription writing itself, who can write prescriptions? And thank you for pointing out the list that I so handily put up there for you. So it depends, right? So you have DOs, you have MDs, obviously, mid-level practitioners like PAs and nurse practitioners. Certainly people like podiatrists, vets. You know, it's always odd when you get a prescription for like, you know, this like ungodly amount of like amoxicillin or something or cephalexin for, and you're like, this dose is way too high. What's going on here? Like, no, it's for my Burmese mountain dog. I'm like, oh, okay, that makes better sense. No wonder his name is Rocket or something like that. Actually, the kids' names are always really weird nowadays. So anyway, but yeah. So right. So again, anyone who has appropriately licensed, they can write these prescriptions here. It just depends on where you're working, who you might be dealing with more frequently. But these are the most common ones you're going to run into. And again, prescription is just anything written, verbal, electronic, anything to be fulfilled by a pharmacist or a lab, et cetera. Right. So if you take a prescription for to get your labs done at Quest, that is still considered a prescription. Now, there's always going to be a certain set of state laws you're going to be working under wherever you go, whatever state you go to, and there's going to be a set of federal laws. Now, in general, these should be pretty synonymous for the most part, but you may find there's going to be some differences between the two. Typically, to keep yourself on the right side of the law, if you go with whichever one is stricter, you cannot go wrong, right? So again, if say something says, hey, you can only write for this kind of drug, or I guess I should say, say federally, you can say, hey, you can write for a week-long duration of this drug, but Florida says you can only do 3 days. Just go with 3 days, right? So you can't go wrong if you follow the state laws there. If it's not addressed in the state laws, just go ahead and follow the federal laws. That's kind of the general rule of thumb, right? Now, in some cases, you're actually finding that this is not holding true. So, for instance, medical marijuana is a big deal, right? Because federally, medical marijuana is a Schedule I substance. We'll talk about what that means in a second, but it is not allowed to be used for any purpose whatsoever. And in fact, it's a crime. However, in certain states, we are now making it so that it is legal. And so it's just a matter of federally, they're just not going after those people, right? So basically, it's that kind of that understood or non-spoken agreement saying, hey, we're just not going to go after this. We're not going to prosecute these sort of things, even though you've legalized it from the state perspective.
Aren't the DEAs going to those medical marijuana little things, whatever, and shutting them down?
It depends. So it could be related to if they're not practicing within their scopes. So again, especially in Florida, because it's a relatively new thing that we have medical marijuana available here, it is very, very tightly regulated. Who can grow it, who can sell it, who can dispense it, who can pick it up. All those sorts of things are very, very specifically written into the law, and so if they are going outside of that, then they can be shut down, right, by the DEA. So it just depends. Some places they've decided to decriminalize it entirely. So if you go to Colorado, you just have it, right, for recreational use. So again, who knows where we're going to be at in 10 years? This could be a totally different talk, and say you guys might be lighting up and vaping right here in class. Who knows? But I would hope not. Hopefully, societal norms would not allow smoking in class. But anyway, who knows, right? So again, things change over time, but sometimes there are some discrepancies there. But typically, if you follow whatever is stricter, you cannot go wrong from that standpoint, right? So again, all prescriptions should be legible. I shouldn't have to say this, but I've seen many, many illegible prescriptions before. They should be unambiguous, should be very clear, specifically what you're saying, what you want the patient to do when they get that medication, right? And so we need to have enough information on that prescription to make sure that other healthcare providers, whether it be nurse, pharmacist, etc., are able to look for possible errors, right? Because are any of you perfect? Right, everyone's fallible, right? Everyone can make mistakes. It doesn't matter how long you've been practicing, how good you are at your job, everyone makes mistakes. And so it's important that you make sure everything is really unambiguous. Don't assume anything, because on the other side of things, on the nursing side, pharmacy side, etc., we need to be able to look at that and be like, wait, this doesn't look right because of X, Y, and Z, and then go back to you and say, hey, did you actually mean this, or do you mean something else? And sure enough, you'd be, oh, yeah, actually, I meant to do this instead. And that's it, right? So basic requirements, this is the Florida statutes here, you're going to follow, and this is for non-controlled substances. When I say controlled, what does that mean? Yeah, narcotics. And narcotics, what does narcotic mean?
Anything in the opiate class.
Okay, so anything in the opiate class, what else? So schedule, so again, so it's kind of this amorphous, like I kind of know what that means, but not quite. So let me define it for you. So obviously there are things you can get over the counter, right? Those are things you can get without a prescription. You can just go and pick them up, no problem, right? You can get those from anywhere. There are things that may be behind the counter, right? So that's going to include things like pseudoephedrine, right? Because pseudoephedrine can be used to make, yeah, methamphetamines, right? So because that is kept behind the counter, so that way you have to show your license, you have to show whatever, you can only get so much, et cetera, right? You don't need a prescription, but you're limited in how much you can get. There are things that are prescription only. It's the RX side of things that you can get it as long as you have a valid prescription for it. Those are still non-controlled substances for the most part. The majority of drugs are non-controlled, even though we're controlling them from the state that you need a prescription to get it, right? When we say controlled, that basically means there's some sort of abuse potential associated with that drug. We'll talk about the different levels here in a second, but that's where you get into things that are addictive, right? So things like opioids, things like benzodiazepines, things like any kind of a lot of the pain meds fall into that category. So lots of things can fall into that category of being potentially used for abuse purposes. So again, using it to get high, etc. And so that's why they become controlled substances. So again, this is talking about the grand majority of prescriptions you're going to write are going to be for non-controlled substances. I guess unless you go into pain management or something specific. But so again, they should either be written or typed. Either way, they need to be legible. I'm having you write them out now. You'll probably never in your career ever have to write a handwritten prescription, but I want you to at least have the experience to at least actually think about, okay, here's what I'm actually writing part by part, so at least you get that experience, that practice of knowing what goes into it. You need to have the name of the practitioner, right? So again, some of these things seem kind of intuitive, but again, we had to put it in the law to make sure that it's going to be allowed, or make sure it's there to make it a valid prescription. You need the name and the strength of the drug. Now, do you need the brand name on there? You don't need the brand name on there. And in fact, in general, we're going to fill it with the generic anytime we can, because that's a cost savings to the patient, right? That is written to the law as well. Now, if you want a brand name drug, what do you have to do? Dispense is written, so you have to write DAW on it if you specifically want the brand. Again, it's very rare that I ever see that. You oftentimes don't need to do that because the generics work just as well as we know based on bioequivalence we talked about previously. You need to have the quantity of drug to dispense. Okay, so how much actually is the pharmacist going to give to that patient? You want to have the directions for use, how are they actually going to take it, and then it needs to be dated. Now, can I just say pre-sign a bunch of scripts and then hand it over to my nurse to go and fill out? Don't want to do that, right? We've had people on rotations. We've had docs on rotations who would pre-fill out scripts and say, hey, here you go, PA student. Patient's just coming in for a well check. Just give them a refill for their stuff, whatever, and just write it in, and you're fine to go. Is that legal? Absolutely not. No PA student should ever do that. So if you're ever put in that position, you absolutely should say, hey, I'm not going to do that. That is outside of my scope of practice as a student. That is not legal. That is also fraud from a insurance sort of standpoint, so don't do that. Anywho, but it must be dated. It needs to be signed by the prescriber on the date signed. Now, for non-controlled substances, for a lot of them, you can actually just go ahead and use it like a stamp. Stamps are fine. If you electronically sign it, so a lot of computer systems will automatically electronically put your signature on there. That's totally fine. We take that very often, but no pre-signing of prescriptions is the thing there. And then they can be communicated electronically, so you can call in a script, you can call in lots of things, you can fax things over. Yes, we still use faxes, even as archaic as it sounds. But you can call those things in, and then basically the pharmacist will then reduce that down into actual prescription. So it's not going to be like the pharmacy technician, it has to actually be the pharmacist or like a pharmacy student intern to do that, because that way, because if there's a mismatch between what you call in, say, hey, I want to give this drug this often, this much, and then someone screws that up, that's an error, right? So again, that's why you want the pharmacist doing that typically. So that's who does that. Now, all prescriptions, unless otherwise stated, are only good for 1 year at a maximum, right? So again, I can write for 1 million refills for a prescription. Say, hey, I never want to see you again, patient, but I want you to take this drug until you're dead. Here's 1 million refills. It's going to be no good after a year, right? So again, that's by law only good for a year. We'll talk about some exceptions to that. But for non-controlled substances, 1 year at max. Now you notice there, having the number of refills was not necessary, but you want to include that if you do indeed want to include refills. If you don't put anything about refills on there, guess how many they're going to get? 0, right? So if you don't specify, they're going to put 0 on there, okay? Now, typically you can write multiple scripts on the same page. That's totally fine, especially for non-controlled substances. However, you typically want to keep controlled substances on a separate script, especially from like a record-keeping sort of standpoint. And then when we talk about C2s in a few minutes here, they have to be by themselves. It cannot be written on. You can't write for amoxicillin plus oxycodone plus blah, blah, blah. You need to keep that stuff separated out, okay? Again, if you don't know what a C2 is yet, as far as like the actual drugs, we'll talk about those much later. We'll talk about what category things fall into in Pharm 1 and Pharm 2 as we come across them. So here's an example of a good script, a good well-written script. So again, you notice here most of the time your information will be pre-printed at the top on these prescriptions here. So you have the provider's name. Notice here you have things like the license number, DEA, and the NPI. This is good because we can then find out, because there's a lot of John Does out there. There's a lot of Deborah Smiths. There's a lot of different names for the same provider. We need to be able to find out who you actually are. And so those are unique identifiers that we can actually go back through and look up to see, is that correct or not, right? So, if I have a podiatrist who's writing for weight loss drugs, does that make sense? No, that is something that would flag me as a pharmacist, and I would actually go back and look through it. Like, okay, well, I'm not familiar with this provider's name. Let me go back and see what they're, who they are, what they do. And if I find that, it would be something I'd want to have a phone call about, right? Or something I may not want to fill. But have your telephone numbers, because that way we can call you back and get in touch with you. And then here you're going to have the patient's name. It's also good to include their address as well. So again, you can have lots of Sean Martins out there. Having the address is good to help make sure you're talking about that specific Sean Martin. Because again, as a pharmacist, if I use my computer system, I just type in Sean Martin, I may have 3 or 4 different people. If I put that under the wrong one, that's a problem, right? So again, having unique patient identifiers is very handy here. Also, date of birth can help with that quite a bit, right? So having the date of birth, very, very important, even though it may not be dictated by the law, that it has to be there, right? So, and again, that's why on my prescription assignments, it has extra stuff that's not required by the law, because those are good practices, good habits to get into, okay? And that's what I'm going to be grading on. So anyway, so you're going to have the date. Some people put allergies on there, which can be handy, especially if it's a new patient to you, you're not familiar with them. Oftentimes we will ask about that with new patients at the pharmacy, but it's good to include potentially. And then so, okay, they're writing for metformin. They put the brand name here in parentheses. 500 milligram tablets, so I know specifically what they're writing for, right? So I know what size tablets to administer to them. They're getting number 100. And they're going to take 1 daily for controlled diabetes. They have the indication of how often they're going to take it. They have the number to dispense, right? That number 100. And they write for 3 refills. So they're taking it once daily. That quantity dispensed should cover how long? Well, just based off of this, say there's 0 refills. About 3 months, right? So sometimes you can write for a few extra. Sometimes insurances will have problems with that, especially for more expensive medications. They may kick that back and say, hey, we're only going to fill it with 90. And so we will make sure that drives with, make sure the patient can actually get it paid for, essentially, right? So again, we may only give them 90, but we'll keep that balance on there. Not really hard, something to memorize right now, though.
What about the months that have 31 days? What about the months that have 31 days?
They will typically have it, so say you just wrote for like 1 month or something, you just write for 30 tabs. The insurances know, they understand that, so that when the patient comes back to get a refill, there's a certain window that they can get those refills done in. Now, if they come back in 2 weeks, they'll get a refill too soon issue with that, and they won't fill it, or they'll have to pay cash for it. Because again, the patient's entitled to all 400 of these pills here based on refills, but the question is insurance is going to pay for it or not, right? Yeah, so that will be not really an issue. So again, you can write for as much as you want at one time for these non-controlled substances, so you can write for 3 months at a time. Now, typically, if it's a new patient or someone you're starting a new medication on, do you want to write for them for a whole year's worth of medication? No, because you have no idea how it's going to work for them. Right? You have no idea. You don't want them taking medication for that long that may not be right for them. So typically, you may only write for a month at first. Have them come back, see how they're doing, see if how their diabetes is going, things like that, and then you can maybe write them a bigger script. And then obviously the refills here, so this way they would get a full year's worth. You could write 5, 6, 7, 8 refills on this, but after a year it's going to expire anyway. We can't do with that. Okay. Some other prescribing errors that can occur here are oftentimes things like omission of information, right? So if I just say, hey, resume pre-op meds. Well, which ones are you talking about? Do I need to do all of them, some of them? You want to be very specific with these things, and oftentimes things like computer systems don't allow you to be this ambiguous. But this is like in the old day when we saw paper charts and things like that. Continue present IV fluids. At what rate? What do you actually want? How much do you want them to get, etc. You want to be specific because oftentimes you may have issues where maybe you fail to stop an old med, even though you're starting a new one. Now you have double therapy. Now you have overlap of things that can occur here, right? Issues that can come about when you don't specify, do you want a short acting versus a long acting, and you need to be very specific about those sorts of things. And then one of the big things you're actually running into from a accreditation standpoint, especially the Joint Commission, I mentioned them as being the main people that come in and give your hospital an accreditation and say whether we're going to reimburse you from Medicare or Medicaid, right? Is having just as needed, right? So as needed is frequently abbreviated as what? PRN, right? So I can write for things like oxycodone every 6 hours, PRN. Well, PRN what, right? So you want to be specific and say, okay, PRN pain. PRN for X, Y, and Z, right? So that way it's very specific because that'll go on the label. Patient knows exactly what to take it for. The thing we run into from the hospital standpoint is when, who's giving the medications in the hospital? The nurses, right? So say a patient comes out of surgery, they have orders for Tylenol, PRN, ibuprofen, PRN. Both of those have an indication of pain or fever. And then they have oxycodone, PRN, orally, and they have morphine IV, and that's all PRN. That's all it says is PRN. Well, now the nurse has to decide which one should the patient get. They're making independent decisions, and is that in their scope of practice? It's not, right? Now, are they, most of them, a majority of them, smart enough to decide what the patient actually needs? Absolutely right, but that is still not within their scope of practice, just like it's not within my scope to prescribe medications to patients. I may know exactly what they need and what they should get, but I'm not the provider, right? You guys are. So because of that, we need to stay within our scope, and you have to be very specific. Okay, I'm going to give Tylenol for pain scale of 1 to 3 for pain, and then I'll do oral oxycodone from 4 to 6, and then IV morphine from, say, 7 to 10. Right? That way it's very clear, so that way the patient or the nurse can go in and say, hey, what's your pain scale? They say, hey, I'm an 8. Oh my gosh, I'm in a lot of pain. They say, okay, I'm going to give you IV morphine, right? So it eliminates that independent practice because you guys are the ones that make the decisions on what they should get and when.
So that's based on the pain.
That's one way to do it, that's the way we decided to do it. It's that way because pain scale is pretty ubiquitous. It's something most people are very comfortable with using. So, but I had problems with this because, with us starting up a new hospital, we had these old school guys who were coming. I remember this one guy, he's an orthopedic surgeon, just the biggest curmudgeon you'd ever want to meet, right? I think he's practicing back in the 1800s or something. But anyway, so I call him up, but hey, Dr. So-and-so, I got these orders here. I need to have an indicator here on when to do this med versus this med. And it's like, the nurses know how to do it. I know the nurses know how to do it, but should we get audited by Joint Commission, they come in and they see these orders here, they're going to ding us for it, right? And that can be a big problem because they've had cases where the nurse was making a decision, patient maybe got over-medicated or maybe under-medicated, and each of those are going to be bad in their own way, right? So again, you may have provider pushback from that sort of thing, but that's why I try to instill good habits in you guys now, so that way you guys are perfect when you go out and actually start practicing for real, right? So again, poor prescription writing. Here's an example. Now, as a pharmacist, I have the innate skill to read bad handwriting, mainly because I have such bad handwriting. However, I have no idea what this says, right? So if you get stuff like this, it's not good. So be very specific, be very clear in your handwriting there. Now, oftentimes this is being supplanted by e-prescribing, so this is less of an issue, but you'll still get these old school guys who will be writing the scripts that look like this, and it's no good. It's call them up and be like, what the heck are you even talking about? Okay, other types of errors. So these are things that are going to be important for your prescription writing assignments because I will ding you pretty quick for these. So these are going to be things that can lead to tenfold dosing errors that are going to be no good. So for instance, misplaced decimals. So if you say 0.1 of something What could that be misread as if you're writing it on paper? As 1, right? It could be misread as 1 if you miss that decimal point. That's a tenfold overdose. No good. So when you're writing something 0.1, you want to have a leading 0. You want to have a preceding 0 there. So I can see 0.1. It's very clear. Even if I miss a decimal, I'll probably know what that means. We need to do that. Don't include unnecessary zeros after the decimal point. So if something is 1, don't write 1.0. Don't write 2.0. Just write 1 or 2. Because otherwise I can miss the decimal and then I can get a tenfold overdose as well. No good. And then other than misreading, if you look at your prescription assignment, I included a list of unapproved abbreviations per the Joint Commission. So it's a good set of rules to follow from an abbreviation standpoint. But and again, you're never going to be wrong if you write stuff out, right? So you can never be faulted for writing things out, but you can certainly be faulted for putting unapproved abbreviations. But things like misreading U. U stands for typically units, right? So I could write 100U or 10U, but that can be misread as 100, right? And so again, giving someone 10 units of insulin versus 100 units of insulin, quite different, right? One patient may have normal blood sugars, the other patient will be dead, okay? Don't want to do that. So just write unit. Now, you may see IU. Anyone know what that stands for? International units. You don't have to write international, just write units and it's understood. That's fine, right? People that write international every time and just like, it takes too long. Just write units. Okay, other things, using micrograms or in like kind of the UG, it can be misread as milligrams. Again, that's a 1,000-fold overdose. Be careful with that. So writing MCG tend to be more clear. Never, ever use QD. It's definitely unapproved because that can be misread as things like QID or QO. You don't want to do that. So just use daily. So once daily, Q24 hours, daily, whatever you want, it's fine. Just QD is no good. And then not writing out full drug names. So this is an old kind of example that doesn't get used too frequently anymore, but MSO4 used to stand for morphine sulfate. And then you had MgSO4. Anyone know what that is? Magnesium sulfate. So again, giving someone magnesium, very different than giving them morphine, right? You want to make sure whoever needs the morphine definitely wants to get it, and whoever doesn't need the morphine does not need it. So be careful with that. And then some other things to just think about, not including the strength and the dosage form, especially with like kids' medications for liquids. Like there's multiple strengths that are out there. You want to make sure you get the correct one and not give them something that, I remember I had one student come up and they're asking me, I got all these different strengths here. I got all these different concentrations. Which one do I use? And I was like, dude, you're a dad, right? He's like, yeah. I was like, you're a little kid. Like, do you want to give them, say, 20 mLs of volume orally, or do you want to give them 5 mLs? He's like, I guess the 5 mLs. I was like, well, there you go, right? So again, use things like try to use a more concentrated form, especially in pediatrics and things like that. So you want to be careful with that. And then don't use things like teaspoons or tablespoons. Just write mLs. It's understood now. Okay. You want to make sure the quantity of drug actually makes sense based on what you're prescribing. So if I write something that says I'm writing for a month's supply, and I say take one tablet BID, they should get how much for that month? Yeah, so BID is twice daily. They should get 60 tabs, right? So then if you write for something like 45, that doesn't make sense, and I'm going to get a phone call too, right? Another one of my goals is to make sure you don't have a bunch of nerdy pharmacists calling you up to clarify your drug orders, right? I want you to get right orders perfectly the first time, so that way you don't have us bugging you, be like, what the heck did you actually mean with this? And you're like, oh, yeah, I totally forgot, blah, blah, blah. Yeah. And I mentioned the DAW, so you guys know that already. So here's the list of abbreviations to watch out for. Again, I'm not going to go over each one of these, but you can see what they could be, what they intend, and what they could be mixed up for, and how it can lead to some of those big errors there. So avoid these when you're doing your prescription assignments for me moving forward, right? We're continuing on. Anyway, any questions from the first half? All right, I'm going to try to finish this up so we can do a little bit of practice at the end here. But anyway, other errors you can find. When you say take as directed, and write that on the script, that's what shows up on the bottle for the patient. So if they don't know what take as directed means, then it could be a problem, right? So if you said, oh, I told you to take it like this, this, and this, you're like, I totally forgot. You're telling me a ton of things, and I glossed over that one particular point of it. So be specific when you can. Some things are very clear as how to take it. So for instance, this is called a methylprednisolone dose pack or a solumedrol dose pack. This is very clear because they'll say on day 1 you're going to take these 6 pills. On day 2 you're taking these 5 pills, and so it has this kind of taper built into it. Similarly with like birth control usually comes as like a little blister pack. So it's on day 1, day 2, day 3, day 4. So that becomes very clear. Those things, it makes sense. But in general, I won't give you an example like that for like a homework assignment. It'll be very clear. I want you to actually write out what the instructions are going to be for that patient, right? Other things you can run into, just to be careful, when you say things like, especially in the ER, say like in a code sort of situation, you say give them an amp of calcium. What does that mean, right? So what's an amp? So that's what I plug my guitar into, right? Really, it means an ampule, where it's just a glass vial. It has that little neck on it. You have to break in order to get the drug out. A lot of drugs don't come as ampules anymore, right? So even that's not very specific, right? So typically, would you say give a vial, right? A vial is typically what you're going to see with most drugs you run into from an IV sort of standpoint. You say, well, give them calcium gluconate, okay, or I'm sorry, give them ampicalcium. Well, then you got to be specific about what kind of calcium you actually want to give. So for instance, here I have calcium chloride and calcium gluconate, okay? So obviously the only difference between these two is the salt form that's actually coming in. One's chloride, one's gluconate. Now look, if you look here, both of them are 10% solution, and both of them are 1 gram. They're both 10 ml vials, and they're both 1 gram of their respective calcium, right? So which one do you think has more elemental calcium in it based on 1 gram? Calcium gluconate or chloride? What do you think is a bigger molecule, gluconate or chloride? Gluconate is probably a lot bigger, right? So it probably means for that single gram, more of that gram is being taken up by the gluconate, so you actually get a lot less calcium in that. Basically, what you need to know from if you ever to use these drugs is it takes 3 vials of calcium gluconate to equal 1 vial of calcium chloride from an elemental calcium sort of standpoint. So if I said give them an amp of calcium, and I meant in my head calcium chloride, I meant that 10 ml is that 1 gram of calcium chloride, and then you were to give them calcium gluconate, that's only a third of the dose that I actually had intended, okay? So you want to be specific. You want to say, hey, I'd like to give 1 gram of calcium chloride IV stat. You know, be very specific with your instructions, okay?
Calcium gluconate is used for the heart than calcium chloride.
Yeah, calcium is calcium for the most part. Yeah, so you could use them either way, but there's other considerations you have to make. Like, okay, do I have peripheral access? Do I have central access? How fast can I give these things? You know, things like that you have to consider. But again, don't assume that everyone knows what you're talking about, right? We talk about something called tight coupling in the ER, where basically from the moment that you have an idea in your head that I want to give this drug to a patient to the time that it actually gets given to the patient is so tight. It can be seconds, right? Between you say, give them a dose of epi. Nurse administers the epi, right? Versus like in your other place in the hospital, or if you're in, say, in the outpatient setting and you're prescribing them something, it could be hours, it could be days before they get actually that medication. There's a lot more time to catch mistakes versus when it's like 2 seconds between when you say it to when the dose is given. So because of that, you need to make sure you're very clear that communication has to happen, otherwise mistakes occur, right? And you'll see that when you go over PALS and ACLS and get to do some of those SIMs and things like that, it'll be very clear to you. Another thing, give an amp of bicarb. Okay, well, we have 2 different concentrations here, right? And both of these are usually kept in the code cards we have in the ER. So for instance, here's that 8.4% versus 4.2. This is double the dose based on the concentration you would see with the infant one, right? So again, which one do you want? You have to be very specific about it. Things like, start the patient on 20 of dopamine. 20 what, right? 20 ducks, 20 houses, I don't know, right? Is it milligrams per hour? Is it mics per kilo per hour? Is it mics per kilo per minute? Is it mics per minute? Some of these drugs are going to have standards, and you can do things like we talked about pumps, right? You can program in, for IV administration of drugs. We can put in some safeguards and actually only put certain units that are available, right? So that way you only have one standard that the nurse can actually program in before the patient gets it. I've seen an error back before we had that available where, or I guess the pump itself had multiples of these. So I had say all 4 of these that were available, and it was nitroglycerin we were hanging on a patient. They're coming in for chest pain, possible MI, so we're getting nitroglycerin IV to help get their blood pressure down. And they said, okay, start them at 20 of nitro. And the nurse went ahead and programmed it in. I believe the provider meant mics per hour, and then, it was mics per minute, and then the nurse put in mics per kilo per minute. So then you took that rate, multiplied by the patient's weight, and then much higher. So all of a sudden that bottle just drains right into the patient. They get really hypotensive, massive headache. Patient did okay afterwards, but again, it was not due to unclear communication between the provider and the nurse who's administering the drug.
Well, and I saw something like this happen where I used to work at. They have, anesthetics. The lidocaine one to 100,000 and the lidocaine one to 10,000, and their color is very similar, so they can get confused and give the wrong dosage to the patient too.
Yeah, and so it's a very good point, between like lidocaine 1% or 2%, and then if they're with epi, they can be 1 to 100,000 or 1 to 200,000. So oftentimes I'll have providers calling up, not providers necessarily, but it could be like some of the ancillary staff, like in the OR. They'll call up from the OR and say, hey, the doc needs some lidocaine with epi. Oh, what kind? I don't know, hold on. Hey, what kind do you want? Okay, they want the 1%. Okay, well, what concentration epi do they want? Oh, all right, hold on. They have to come back and get that. Well, how much do you want? I don't know, 1. 1 what? Do you want a vial? Do you want a syringe? Like, these are things like, okay, well, being very specific, we try to get to the bottom of things, but otherwise you can have big errors that can occur there, right? So, looking at things like, inappropriate drug prescriptions, you need to be cognizant of things like, what are the contraindications for the patient? What other interactions might I see with other medications they're on? You always want to make sure you get a really good full history and include things like herbal supplements, over-the-counter products you may be taking. And again, if I ask you what medications do you take, they may not necessarily be forthright with saying like, hey, I take, St. John's wort for my depression, or I take ginkgo for my memory, or something like that, right? And again, like, I don't know what your personal stances are on herbal supplements, one way or the other. It honestly doesn't matter, because when you're talking to them, you want to go in with a non-judgmental sort of mindset. Because if you say, hey, what do you take for, what do you take? And they say, oh, I take ginkgo for my memory. That stuff doesn't work. Guess what? The patient's just shut down. They're not going to give you forthright information. They're not going to tell you anything. They're only going to tell you what you want to hear, and that's no good. You need to have good open communication there. So again, you may say, okay, well, it's not something I would recommend, but however, that's totally fine. You take, you want to have a good stance with them, right? Because again, you need that open line of communication. Otherwise, the patient shuts down. You're going to be missing out on big stuff. I mean, I had one lady who came into the ER. She had a massive head bleed. She ended up dying because she was taking warfarin for her AFib, and then she ended up taking ginkgo for her memory, because she's getting older and losing her memory there, and then did not know that there was an interaction there to where ginkgo itself can actually have some antiplatelet effects. So that on top of blood thinner, just bad news, right? So you need to be very careful with this to make sure, because some these herbals, if you think they don't work, guess what? They still do stuff. They still do things in the body. You need to be aware of that and be cognizant of it. Okay. Look at things like incompatibility between drugs. This is more of an IV sort of problem, but if you try to give two drugs at the same time, they may precipitate out. That could, one, ruin your line. So if they have like a central line of the patient that took a whole procedure to get that in, and you screw that up, guess what? You got to take it out and put a new one in. There's a whole other procedure you have to do there. Or it could precipitate in the patient, causing an embolus. That could be bad, right? So you got to be careful of things like that. And then also looking at disease state interactions, like looking at their actual full disease state list and see, well, how might that be affected by the medications I'm giving them? If they have diabetes and their blood sugars running at 200 on a normal, giving them something like a steroid is going to raise that up. It can be antagonistic, right? It's going to be a problem. You need to take that into account. So again, looking at compliance. So again, this is how well your patient is going to be adhering to your regimen. There's kind of four main types you can see there. So one, like the patient fails to obtain the medication. When might that occur? They can't afford it. It's a big one. What else? Yeah, maybe they forget. So again, this is even like getting it from the pharmacy in the first place, right? They may decide they don't need it, right? I can't tell you how it used to make me so mad when I was first interning. Is between my first and second year of pharmacy school, so I was still pretty naive, didn't really know anything about the world, and I had these people come up with these scripts from the ER. And they would say, and this is like a CVS pharmacy, they come up with their scripts in the ER before, say, like, Augmentin for like a toothache, and then for hydrocodone, acetaminophen, right? Some Lortab for their pain, and say, oh, I just want the Lortab. I was like, you just got discharged from the ER because you had this tooth pain. They're giving you antibiotics for it. Don't you want to treat that? Like, no, just give me the Lortab. Right? Obviously, pain-seeking behaviors. These are things that we try to crack down on, but it gets more and more difficult. Especially patients can be really convincing sometimes when they're talking about pain. But anyways, that's an example of not actually obtaining the medication due to intentional non-compliance. Now, obviously, they're failing to take it as prescribed. That could either be an error with maybe the communication you gave to them. It could be a problem that they're not remembering, things being dictated inappropriately, things like that. Prematurely discontinuing. We see that a ton with antibiotics. Patients will take it for a few days, they feel better, and they stop taking it. Need to continue that all the way through. And then patients taking it inappropriately, so maybe taking only, say, half doses because they can only afford to get it, every other month, right? Or they're maybe saying, well, a little bit of this drug works pretty good. Maybe if I take extra, it'll work even better, right? Things like that. Other situations that, again, are still considered non-compliance. Again, about a third of patients fail to ever get prescriptions filled. Most of the time it's going to be cost, but you may find there's some issues with things like drug shortages. If it's a specialty compounding product, if you can't find a pharmacy to fill it, the time of day can be important as well. So for instance, we opened up Nemours, Lake Nona at the time, this is back in 2012. Anyone know what Lake Nona looked like before, like, say, back in like early 2000s? Swamp and cow pastures, like that was it. yeah, there's nothing there, right? So we're still building up as we speak. And so when we first opened up Nemours, we had an ER. We were still discharging patients from there, but we didn't have any 24-hour pharmacies available, like anywhere near us, right? And so we were having a lot of times patients coming from the airport, they're coming from Disney, they don't have access to 24-hour pharmacies. They can't get their meds, right? And so that was becoming an issue. We'd have to give them doses like to leave from the ER. We'd have to do things to try to get around that. Now it's become less of an issue, but that's a concern, right? The time of day can be an important factor. So just consider that, and also, they have a lack of perception of the need for the medications, or sometimes they'll take a medication like, well, I feel worse than when I started. I've taken this beta blocker for my hypertension, and I just feel crummy all the time. Like, what's the point of even taking it, right? Things like, depression medications, they take like 6 weeks before they really kick in. If you start taking a medication for 4 weeks and you're like, I don't feel any different, I'm still depressed just as I was when I started, you're going to maybe discontinue it earlier. These are things that education can kind of help with. So when the patient's taking it, not as prescribed, it could be due to, say, a wrong dosage, wrong frequency, wrong route. There's lots of different things that can come into this. Wrong technique of administration. Remember that video I showed, that GIF of the lady who's using her inhaler on her neck? Like, these are things that happen, right? It's not completely fabricated, I can assure you. But again, communication can be super important here. Making sure, I oftentimes do a teach back method where I say, okay, here's how I want you to take this, and then explain it back to me how you're actually going to do it. Because you can say 2 tabs twice a day, and that can mean different things to people. They can say, okay, well, I'm taking 2 tabs a day, so I'm going to take 1 in the morning, 1 at night. Or some people may think it takes 2 in the morning, 2 at night. These are things that have to be clearly defined for the patient. And if they're explaining it back to you, that can alleviate some of that. Right. As I mentioned, antibiotics is a big thing when they discontinue medications, or sometimes they say, hey, the bottle's empty, I must be done. I must have fixed my hypertension. That 1 month supply, right? These are things you have to make sure they know about, right? Know if it's a limited time medication or something they're going to be on the rest of their life potentially, right? Or they, like I mentioned, stop taking things due to lack of perceived benefit. If they don't feel any better, or if they feel worse potentially due to side effects, that can be a problem there. All right, patient taking medication inappropriately. This becomes a big issue, especially with older folks who typically tend to be on a fixed income. They are typically pretty frugal, right? So again, they will do things like share medications with others. Oh yeah, I had that infection last year. Go ahead and take some of this, right? Taking someone else's medications maybe from an abuse sort of standpoint. So you can have, one of the things with opioids is that tolerance develops over time. So you can have these little old ladies, 90 pounds sopping wet. They're on like doses of methadone that would like kill a horse, right? And then their idiot grandson goes and says, oh, grandma's got methadone, I'm going to try some of that, and all of a sudden he's dead, right? These are things that have happened due to the effect of abusing some of these drugs and not understanding things like dosing, intolerance, etc. So it's always a big concern there. So leading into controlled substances, so I mentioned this is anything that we feel, or the DEA feels, has an abuse potential, right? So abusing it for euphoria purposes, or that's usually the big one, right? So these are things that the DEA has decided we want to control these. We want to have a tighter rein on these, so that way they're not just being given out like like candy, right? Essentially. And so this means that in order to prescribe controlled substances, you need to be registered with the DEA. Now in Florida, for a long time, because we're backwards from everywhere for the most part, we're very slow to initiate things that many other states do. Now you guys will be able to write for controlled substances, right? But you need to be registered with the DEA. You have to make sure you take the appropriate classes and have all the CEs and everything, and it needs to be within your scope of practice, right? So again, if you're working in an endocrinology clinic and you're writing for opioids, like that doesn't make sense, right? You need to make sure if you work in the ER though, that does make sense. And actually, we'll talk about this either next semester or the following. But there's been a whole new set of laws that just came out and actually initiated July 1 regarding acute pain treatment, right? So only getting a 3-day supply for acute pain treatment, things like that, to try to curtail the opioid epidemic that we're experiencing here. Anyway, but we have to have the DEA number in order to make sure that we can say that, yes, you are actually licensed with the DEA, to make sure that you can prescribe these. And then they break them down into 5 different schedules here, okay? Basically going in descending order of abuse potential. So our C1, Schedule 1 substances typically have the highest abuse potential. 5 has the least. 5's kind of the wimpiest of the narcotics here, right? So Schedule 1, though, the main difference here between a 1 and a 2, a 1 has no accepted medical use, okay? So the DEA has decided there is no acceptable medical use for this substance. We are not going to allow you to prescribe it at all. Possession of a Schedule 1 substance is still considered a felony federally, okay? You can find that sometimes the states will have their own Schedule 1 list, and in fact, when we had things like the, you guys remember like the bath salts and like the synthetic marijuanas, a lot of those substances got added onto the Florida Schedule 1 list because we could do that. We can initiate that a lot faster than they could on the federal level, right? So the Schedule 2s, though, they do have an acceptable medical use, but they have the highest abuse potential. So 1 to 2 is probably the same abuse potential between those two, but 2 has an acceptable medical use. Okay, these are your oxycodones, your morphines, your amphetamines we use for ADHD. Those all fall into that category. 3s are going to be a little less likely to be abused. 4 even less, and then 5 again the wimpiest of the bunch. Okay. Now, the big thing with this is just more from a documentation and a regulation sort of standpoint as far as how strict we are with these prescriptions, and I'll show you the difference here in just a second. So the additional requirements you're going to have for a scheduled substance are going to be basically you need to have the name and the full address of the patient, or sometimes you may be giving some of these controlled substances to animals. Can you think of any situations where we might have to do that? Yeah. Okay, it could be anxiety. I didn't even think of that. That could be one. So if you're really anxious, maybe like a little chihuahua, you can give them a little bit of Xanax or something. A puppy Xanax. The other big thing we see is animals with seizure disorders. So phenobarbital is a common one. That is a controlled substance, right? So you need to have the owner of the animal that's on there. And if it's an animal, you have to specify the species of it. You know, so at least say if it's I don't know, your fish you're giving morphine to or something, I guess you could put that on there. You want to have the full name and address of the prescribing practitioner, which is why I make you include that on your scripts, because again, you can't go wrong if you include more information than what you really need, so that's good. And then you need to have the written and numerical quantity actually to dispense. So what I mean by that is you can write for 10 tabs, but say someone was saying, you know, was addicted to their opioids and they say, man, 10 tabs is not really a whole lot. What can they do? Add a little 0 right to the end of there. Boom, now I got 100. Ooh, that's nice. So by writing 10, T-E-N, and then the number 10, helps to alleviate some of that, right? So again, you want to be textual and actually write out the actual things there, so that way there's no ambiguity. There's no way to turn TEN into 100, right? Now, as far as from the standpoint of like refills goes, this is also different than what you see with non-controlled substances. We mentioned for non-controlled substances, you could write up for a year's worth. So I could write for, say, a 30-day supply for something I'm giving once daily and write it for 11 refills. That's totally within the scope of the law. For Schedule 2 substances, these cannot be refilled. Okay. Now, on a test, if I were to ask you for this class, I would say, hey, you have morphine, a Schedule 2 substance. How many refills could I write for that? And maybe give you a list. You'd say 0, right? You cannot write for refills of this. You can write up to a 90-day supply. So this becomes a problem, especially with like ADHD medications, right? So you have someone who's on Vyvanse for their ADHD, especially like, you know, if it's a young kid, you know, they're not picking up their own meds. Usually the parents have to do it. So they either have to go and get a new script every single month, and usually they'll do that until they kind of figure out what's right for their patient, and they have to go to the pharmacy, fill it every single month. And then eventually, once they get kind of settled, they can maybe do a 90-day supply. So you can either do that as like one prescription, just, you know, dispense 90, or you could do it as 3 separate scripts that you'd actually post date. We do that very frequently, where you'll say, you know, today's say August 3rd, and we're going to fill this first one on August 3rd. The next one you can fill on September 3rd, and then October 3rd. Can't believe it's already going to be like October pretty soon, but I think my months are right. That's how it works. Yeah, there you go. Time is the flat circle. I don't even know where I'm at anymore.
With like mail order pharmacies, do they get 90 at one time?
It depends on how for one, so it could depend on the insurance companies, like how they'll pay for it. Some drugs may only pay for a month at a time. Sometimes they'll do 3 months. There's a lot of different factors that can go into it. They may get all of it, or they may not, just depending. But yeah, so very frequently, especially for like ADHD meds, you'll see it where they actually will post date it. Again, the doc's not pre-writing the prescription. They're just simply just saying do not fill until this date, and the pharmacies will honor that. So that way they can have keep hold of the prescriptions, and you know, parents not going and getting it all at one time, right? They also have to be written on tamper-resistant security paper, which means you can't just photocopy a million of them and just take them to every pharmacy in town, right? I'll show you an example of what that looks like in a second. And C2s cannot be scheduled or transmitted over the phone, so the patient actually has to bring in a hard copy prescription from the provider to get that filled. Okay? If they try to call it in, we'd be like, no go, buddy, no thanks. 3s, 4s, and 5s can be refilled, but this is a maximum of 6 months. So I could write for, say, like a month's worth of say, Xanax for the Chihuahua or whatever, and then I could write up to 5 refills. I have no idea if it's a Chihuahua or not. I just think of like anxious dogs, and I think of Chihuahuas. But I don't know if that's correct or not, but my experience has been that. Anywho, so so you can do up to 6 months worth. If you write for anything beyond that, we just won't fill it. We just won't honor that, anything beyond 6 months. Okay, those are the main differences there. Here's an example of what the prescription proof paper or the counterfeit resistant paper looks like. If you photocopied it, just say void all over it, and so that'd be a pretty clear indicator that's not going to be useful. And actually, this has to be gotten through specific providers of the paper, so we keep track of it. So that way, you don't have just like Joe Bob on the street ordering from Amazon Prime, a million prescription papers so he can write his own scripts. That doesn't work that way, right? It has to be actually done through certain companies that are licensed with the DEA to do so. Okay. And again, especially for C2s, they have to be handwritten, signed by the prescriber. No stamps or anything like that have to be hand signed. So, for instance, at Nemours, we have it set up to where all of our electronic scripts, or the grand majority of scripts we do are electronic. Anything non-controlled just come out on regular printer paper, like you get from Office Depot. Anything that's controlled automatically comes on paper like this, and then it has to be signed by the prescriber themselves. Non-controlled stuff will just say electronically signed by Joe Blow. Everything else would say, you actually had the real signature on there. Right. Yes, sir.
How does it work for like you're in the ER, you're given
Mm-hmm.
How do you get that process as far as?
So it's a lot different in the hospital sort of setting, where as you will have certain providers who are set up to prescribe those meds. So for instance, like if I had one of my endocrinologists who was writing for ketamine, that'd be pretty odd, right? So that would be something we'd probably have to raise an eyebrow to. But it's like an ER doc and they're trying to set a bone or something like that. That makes sense, right? And so we would just allow those scripts to go through. We have tight controls on it from like the machines we use to dispense that, so that way we have accurate records of who's pulling meds from the machine, and then when they administer it, that document all of that appropriately. So in that instance, it's a little bit more kind of free, where only the right people can get access to it, but it's more controlled so than giving Tylenol or something. Yeah.
So as a PA, we have to get it signed from the physician if it's a controlled substance?
So no, not necessarily. So for instance, if you get signed up with the DEA, if you have your own DEA number and do all the appropriate license, the CEs and everything, you can write your own controlled substances, right? So you could do that. More frequently, what I will see, especially with the hospital, like say you're writing for an inpatient order for ketamine for a patient, we will have mid-level providers. So we have like CRNAs, nurse practitioners, PAs. They can write for orders for those controlled substances because they're under basically the hospital's DEA, or the hospital itself has its own DEA. But they are not necessarily, and again, this is just our policy. Instead of having every single mid-level go and get signed up with the DEA, they said, well, just no point. Let's just take it to your attending, get them to sign it, and then you're good to go. So where you work will be dependent on that. So they may want you to get signed up for it. They may not, and just say, hey, just have your attending sign it. You'll still write the script, but then just have them sign it. So in the pharmacy or in the hospital setting, yeah, we'll actually have machines where from the pharmacy we'll dispense things out to the machine, and then the nurse says, hey, I got an order for morphine for my patient, just has a broken bone. Then go to the machine, select the patient, it'll pop open, they'll get their med out, and then they administer it. It's called an automated dispensing cabinet. It's pretty ubiquitous in hospitals. Mm-hmm. Yeah. So anyway, so just a quick quiz. Federally, which schedule do these drugs fall into? So anyone know what morphine falls into? It's a class 2. It's a C2. It's a very high abuse potential, but it has an acceptable medical use. Okay. How about cocaine? That is also a C2. I know it seems odd. You think cocaine? It's actually a C. Yeah, it's used for like ENT procedures.
Like ENT.
Mm-hmm. Absolutely. Yeah, we used to have a little bit of cocaine over at Nemours, but then our ENT doc said they would use it, and they didn't use it, and we expired it, and that was it, right? I won't tell you how we expired it, but anywho, don't worry about it. But yeah, it's a very good anesthetic. It's a very good vasoconstrictor. It's great for like ENT procedure. It helps to keep your site nice and numb and not so bloody. But that's a Schedule 2 because we have an acceptable medical use for it, right? Now, on the other hand, something like methamphetamine, what is that? That's actually, methamphetamine itself is a class 1. Now, we still use amphetamines. We use things like dextroamphetamine. We use things like amphetamine itself for things like ADHD, right? We use lisdexamphetamine. Methamphetamine itself is not, does not have an acceptable medical use. That is still considered to be a class 1 substance, right? And again, I'm not going to ask you to memorize these and ask you on the test. If I have anything about a controlled substance, I will tell you what schedule it is, right? So it's going to be more knowing information. I just want to kind of illustrate things you might not think are actually have medical uses do, and things you might think that do don't, potentially. How about marijuana? That is a Schedule 1 substance federally. That is why there's a discrepancy between the states who say, hey, we're going to decriminalize this, or hey, we're going to allow this for medical use, versus federally said, hey, this is a Schedule 1 substance. So the District of Columbia has medical marijuana that's available. So I can go to the White House and I can actually light up a joint for my glaucoma or something, but federally it's still considered a Schedule 1 substance. Okay, so again, America's weird, as it turns out.
Isn't it that you only can have like a certain amount on you?
Yeah, so sometimes, so based on the, guys, shh. So based on the state, it can depend like how much you can have and things like that. So again, every state's gonna be a little bit different. But yeah, so anyway, so just some things are weird out there. Again, for the most part, you should not be prescribing medical marijuana unless that's like part of your practice and that is something that you do. Actually, one of our adjunct professors over at Nova, he worked in a clinic. That's where he did. He based his writing scripts for medical marijuana predominantly. So. You never know what you may find yourself getting into, right? It was right next to the Wendy's and walk over. Yeah, Taco Bell. Okay, so just one couple final points here. So depending on which state you're in, you may find some drugs may have a schedule and some drugs may not. So for instance, there's a drug called carisoprodol. The brand name is called Soma. Now, this drug in many states is not a controlled substance, but here in Florida, we decided we want to make it a C4. We said, yes, there is some abuse potential. We said, let's go ahead and make it a C4 because we saw so many people are using it and abusing it, overdosing on it. We call it the Soma coma. People come into the ER after abusing this drug because they are just like out, like near intubation levels of CNS depression. Usually it's a muscle relaxant, yeah, typically. And again, if he's directly into chronic pain management and things like that, so a lot of muscle relaxants will get used by those patients or abused potentially. And then there's been changes too. So for instance, there's a drug called tramadol, which is kind of a wimpy opioid, it's kind of partial opioid. It used to be non-controlled, so it was great for mid-levels because you guys could write it, with impunity. They saw enough abuse of it. Anything can be abused, as it turns out, and so people were abusing this because it's easy to get a hold of. You could write for a year's worth of it at the time, and so it made it a C4. So at least now, okay, you can only have 6 months worth.
Because once you ingested it, that your body would like transform it more into something that, I don't know, more like morphine or.
So codeine will do it. Codeine gets turned into morphine, but tramadol itself was active at the opioid receptor, so that you didn't necessarily see. Yeah. So that wasn't the issue with there, because like for instance, morphine's a C2, codeine's a C5 typically. So even though that gets turned into morphine, it doesn't have as an intensive an effect as you would see with giving like a big dose of morphine.
Not a dumb question, but how often you control substances that
Never that I've seen. It's kind of once they get lumped into that, they're kind of stuck there because it's not like people are going to abuse them any less. Like if anything, they'll abuse them more when they become uncontrolled. So maybe it'll happen, but I haven't seen it. So maybe like something like marijuana, like say for instance, 10, 20 years down the road, we've gotten to a point where we decriminalized it enough to say, okay, hey, it's just going to be a non-controlled substance. That could happen. Yeah. Because again, if you think about it, Schedule 1 substance you think has the highest abuse potential. So are you telling me that marijuana has the same abuse potential as morphine? I would venture to say absolutely not. That is no way the case. But because of the way it's been scheduled, that's the definition that's applied to it. So it's one of those things where it may seem odd to be like, well, marijuana is way safer than morphine. And for the most part, yes, I would say that is true. But that's just federally how it's done, right? Which is why you're starting to see that trend more towards states decriminalizing things as you go forward. But anyway, it's a whole hour-long conversation we can have later on. The other big one is hydrocodone. That moved from a C3 up to a C2. So that bumped it up in categories because a lot of people abuse Lortab very frequently, but they can get 6 months of it at a time, versus now they can only get up to 90 days at a max. They have to get a new script every time they go in to get it. So that was a highly, highly abused drug. And in fact, if you look at top 100 drug lists, hydrocodone is always at the top. It was number 1, number 2 every year because a lot of ERs are prescribing it. They're just handing it out like candy, and now it's more controlled. So basically, hydrocodone itself is very rarely ever given by itself. So it's always usually hydrocodone and acetaminophen. So basically, anything with hydrocodone in it is a C2 now. Yeah, but yeah, that's the thing you'll see most frequently is hydrocodone and / acetaminophen. Yeah. Okay, so any questions on that? Everyone feeling okay? All right, let's do a couple of practice math problems. I think that'll be beneficial to you.